Welcome, everyone. My name is Dr. Ruemu Birhiray. I'm joining you today from Indianapolis. Today, we will be talking about what we're most excited about in the treatment of follicular lymphomas at the last ASH meeting and the emerging data that have been presented over the past year. And I have two esteemed colleagues who will be joining us today, Dr. Joshua Brody and Dr. Julio Chavez. I practice in Indianapolis. I'm clinical professor of medicine at the Miriam University Medical Center here in Indianapolis. My interest is in hematologic malignancies. So thanks for joining us today, and I look forward to this erudite conversation moving forward.
My name is Julio Chavez. I'm from the Moffitt Cancer Center. I'm also a hematology oncologist. I focus on lymphomas. I'm a clinical trial investigator, run clinical trials in all varieties of lymphomas, particularly in B-cell lymphomas.
Dr. Brody.
Ruemu, thank you so much. Great to see you guys all again. My name is Josh Brody. I run the lymphoma immunotherapy program here at the Icahn School of Medicine at Mount Sinai here in New York. If you've never been to New York, it's really quite lovely. It's right next to New Jersey, so please come visit us. And our focus here, as the title implies, is on developing novel immunotherapies for all types of lymphomas. And that has been our focus both in the lab and in translational clinical trials and in our conventional practice. And I think as we're going to discuss some of the most exciting bits of progress there have been in the field of bispecific antibodies for aggressive and follicular lymphomas.
I would like to start with a very broad question before we begin to delve into data. The first thing I'd like to ask you is, how did you enjoy ASH 2024?
I thought it was fantastic. First of all, San Diego's got the best fish tacos, I think, of any city in the country. And I know that there's a lot of other cities that would say, no, I would say it's San Diego. So in that sense, a pleasure, and also scientifically and medically, also a pleasure. Again, we are just, I think, very lucky to be in this era when we're making progress in getting patients' immune systems to kill their own lymphomas and other cancers as well, but probably none as much as lymphomas. And excited to see the results of some big, mostly phase 2, but also inception of early parts of randomized big phase 3 trials for aggressive and follicular lymphomas, bispecific antibodies at the forefront of that. So it was a very gratifying annual ASH meeting, but I think no part of it more exciting than the progress in bispecific antibodies.
I think it was a great meeting, and particularly in follicular lymphoma, it's kind of like a confirmation that bispecific antibodies kind of dominates the field, actually. So to the point that it's probably our therapy of choice on patients with relapsed refractory follicular lymphoma. There were several trials out there. I cannot imagine how many trials were out there that were interesting to show. Like what I was more interested was in the combination, especially the combination with the standard of care treatment for follicular lymphoma, like epcoritamab plus R square in the frontline setting and in the relapsed refractory setting, show very impressive data in this patient population. The single agent actually study also shows a good proportion of patients that are still in remission, especially those who have kind of deep remission, including MRD negative disease. But also interesting studies was a single agent mosunetuzumab in low tumor burden follicular lymphoma. It was a single center study, kind of like an investigator-initiated trial, actually, that showed very good responses in the patient population that actually is justifying the current SWOG study that is randomizing mosunetuzumab versus the standard of care for low tumor burden follicular lymphoma, which is single agent rituximab. I think I'm looking forward to what the future is going to show. Other studies, particularly with bispecific antibodies, the odronextamab data actually looks very good. It's an interesting poster about the pattern of CR in patients that receive odronextamab. I think one of the challenges with odronextamab is the logistics, to give in 2 consecutive days, especially during the step-up dosing. But then after that, it's a little more kind of straightforward. So that's probably a little bit more difficult to carry out with odronextamab, but the efficacy is there. So it's kind of showing that the bispecific antibodies actually dominating follicular lymphoma.
Very good. I see my friend Dr. Brody, nodding his head. So, what he said is so packed. So, what I'm going to try to do is unpack it and break it down a little bit at a time, so that we can do it in a more methodical manner, so that people don't get lost, right? Because the data is so exciting, and I always say that those of us who are nerds who get so excited by data can sometimes get lost in our own heads. So let's sort of slow down a little bit and break it down. So the first question I have for you is, so going back to epcoritamab, Dr. Chavez talked about epcoritamab in combination with rituximab and lenalidomide, and just how powerful that data is. So that was subcute epcoritamab, that was R squared, and it was time limited. So let's talk about that data for all of these components and tell me what you think about it.
So, I mean, I got to agree with what Julio said. Broadly speaking, bispecific antibodies absolutely dominating, CD3 by CD20 antibodies especially, but also even a new CD3 by CD19 bispecific antibody. But focusing on some of these most exciting epcoritamab in follicular lymphoma data, yes, as you and Julio have both said, I think the future is in the combinations. Although these are great monotherapies, that's what medical oncology is all about, is combining things that can be safely combined to get longer progression-free survivals and maybe even cures. We act like follicular lymphoma is an incurable disease. No disease is incurable. Every disease might be curable. We just need to find the cure. So the path to cure is it's first to getting extremely high complete remission rates. And then Julio was implying, and you're explicitly saying, the R squared plus epcoritamab data, I think amongst the most exciting in terms of getting extremely high complete remission rates. And we already have multiple contexts of R squared plus epcoritamab. We have even some small frontline R squared plus epcoritamab data. And the easiest example of that is Genmab 02 arm 6 trial, arm 6 of that trial, of the 02 trial, in which we had a small number. It was, just a couple dozen patients, but response rates above 90% and extremely high complete remission rates. We haven't followed those patients for only a couple of years, but so far the durations of complete remission are extraordinarily high. So in the frontline setting, and now this is being studied in larger randomized trial, we don't have that data yet. R squared plus epcoritamab, extremely high potency, and I would say very well tolerated. I've given a lot of patients that exact combination on trial only, not off trial yet. And for all of my patients that have had adverse events, they've not been from the rituximab and they've not been from the epcoritamab. They've almost all been from the Revlimid, a medicine we've been comfortable with for 20 years, but it still has lots of little side effects, cytopenias, rashes, a few other things. So overall, I think that the safety and tolerability of R squared plus epcoritamab has looked comparable to R squared, pretty much, from my patients. That's anecdotal, my patients' experience, and also from the little bit of data we have. And then we have these larger studies of R squared plus epcoritamab in the second and later line settings, but the results are almost the same, extremely high response and complete remission rates. And it seems like the durations of remission are extremely long, but we haven't even followed these patients nearly long enough. The majority of patients still in remission. So again, super high efficacy, and I would say similar safety to R squared with not much additional toxicity added by the epcoritamab. There was certainly some amount of cytokine release syndrome, but it was almost entirely grade 1 and grade 2. So, not much different than the fever you get from a flu vaccine or something like that. So it's not that there are no side effects, but in terms of overall tolerability, pretty well tolerated combination therapy.
Dr. Chavez, for those of us who are out in the community, because these regimens, follicular lymphoma is really not a disease of academic medicine. This is a disease that is treated in the community. So how do you guide, your colleagues, your friends, or people who are calling you to say, imagine that this regimen is approved. How would you guide folks to use this regimen without feeling anxious about doing it?
Yeah, I think it's a good idea. Whenever we have a regimen that is approved, how can we translate this into the community? And it requires a lot of work. So far, at least in our experience here in Florida, community centers are a little bit slow to the applicability of bispecific antibodies in the community. So we're trying to establish some type of partnership with the community, and maybe we recommend patients to do the step-up dosing at our center, and then once they go through the step-up dosing, they can safely do the consolidation of the further cycles in the community. Because as Dr. Brody mentioned, there are cytokine release syndrome. Approximately 50-60% patients get it. Majority of the time is CRS very 1, but always in the community hospitals that don't have a familiarity with the treatment, they will probably be a little bit concerned or uncomfortable to do it. So, but also what is true is that, past cycle 1, from cycle 2 and onwards, is very rare to see actually cytokine release syndrome. And especially true with the new regimen that they're using with epcoritamab, with the optimization regimen that is fully outpatient. So I think there will be more uptake the more they learn. So what I'm doing is I'm encouraging community oncologists to start using epcoritamab now that we have approvals. We have approvals for follicular lymphoma, for DLBCL. We kind of work in partnership to make sure that let's start here the initial step-up dosing, and then subsequent cycles they can do in the community. So that seems to be working well for majority so far. And that's one point in regards to cytokine release syndrome. But something else that we see with bispecific antibodies are infections. So especially for patients who are receiving bispecific antibodies after CAR-T or continuous treatment until disease progression. So infections are important. So I always tell them, make sure that based on patient population, provide prophylactic antibiotics and also monitor immunoglobulin levels in order to provide IVIG if needed. So those are the two key components I discussed with the community.